abdominal examination which showed a enlarged liver, and that was non-tender, smooth, regular margins, and total span of 12 centimeter. The renal graft was non-tender. Basic workup lab were normal, except for erythrocyte sedimentation rate, which was 130 mm per hour. Liver function tests were normal, except for gamma glutamyl transferase, which was on the upper limit of normal, and slightly AST was also on the upper limit of normal. As a workup of weight loss thyroid function test, TSH was also normal. The only thing to be noted here, another thing to be noted here was that his surface antigen for hepatitis B was positive. Cytomegalovirus virus PCR was negative. So, keeping in mind the history of generalized weakness, weight loss, we planned for CT to show you the image of the CT. If we are able to appreciate any pathology, then we should share in this on this CT. If we are able to appreciate any pathology.
So, any comments?
Zahir, you should ask people. Oh, but people are replying back. Javeria says maybe nodules. Fivzia says lesion liver. Faiza says diffuse liver lesions. And none of the other fellows are replying. Only attendings are brave.
Nodules. Okay. So
developing abscesses, says Fivzia. Okay. And Faiza says diffuse multiple hypodense lesion, over, not hypotension lesion. Hina says multiple nodular lesion shadows. Sabiha says microabscesses. And yeah, Asma and Zahir, that's what the answers are. And Faiza's asking Didi instead of us asking Didi. She.
Okay, so there is a lesion, Dr. Kashif.
The lesion.
Next.
Next.
Oh, Faiza's telling Didi. She's saying, do you want to wait for Didi or do you want to carry?
Faiza, wait a second, when cheating ho jayegi.
There is a lesion in the liver, the segment 7 of the liver. So, what are the DD now? Next,
wait, so can you tell us what these nodular lesions that people thought they were, what those are?
No,
everybody said nodular.
There is no nodular lesion. Just there is this large hypotense lesion in the liver in the 7th segment.
So basically, it's a triphasic CT. So in that case, obviously there is this arterial phase and venous phase. So we could say that in arterial phase, these lesions look like nodular type of lesion. But the important thing is that in segment 7, there is a hypodense area, which the arrow is indicating, which is showing something pathological.
So we will give you a summary and then DD. Summary.
Okay.
The summary was that she was 40 years old, diabetic, 12-year post-renal transplant. She presented with weight loss and generalized weakness, and CT was showing a lesion of 3.5 into 3.5 in segment 7 of the liver. Now, are we able to give any differentials? We should share.
So Faiza has said multiple abscesses can be bacterial or fungal. Rabia says cystic lesion may be hydatid cyst.
Also keep in mind hepatitis B surface antigen positive.
Okay, keeping that in mind, Faiza says EBV related lymphoma and asks EBV, do we have EBV serology? And Khalid says hepatocellular carcinoma, TB, lymphoma, nocardia. So
Okay.
far, abhi tak kitna hi aaya hai?
Okay. आगे चले?
Oh, one more. Pfizer, we have two Pfizers. So Pfizer Ali says cysticercosis lesions.
Oh no. Okay.
I'm not hearing anything from who else are the fellows? Let's see. We have Zahir Tudri. Mariam. Mariam is a fellow. And Dr. Sohand also. And okay. And then Pfizer Ali says we have also seen histoplasmosis like this. Pfizer, where are you from? Since you have more than one Pfizer.
Sir, I'm coming back from USA. So we have
You're coming
seen
back from
just
the US.
yeah. So sir, बिल्कुल इस तरह की lesions we have seen in blasto में भी देख चुके हैं, histo में भी और bartonella में भी देख चुके हैं actually. But again, we don't see much of those dimorphic fungi here, but like we have seen such things back there.
Okay, great. Rabia, well, we don't see it, but unless we look for it, we won't find it. So I'm glad you mentioned it. Rabia said Candida abscess or tuberculous abscess, and Terim says NTM. Asma,
Okay.
those are what we have so far.
I think fine. Okay.
Yes.
Let's move.
We'll move forward. So differentials.
Hepatoma.
We thought of
Hepatoma, metastatic disease, abdominal TB including liver, involving liver, hepatic fungal infection that could be candidiasis, Cryptococcus aspergillus, or lymphoma, hepatoblastoma, and maybe liver abscess, bacterial RMA. Triphasic CD abdomen was reported as arterial enhancing lesion of 3.5 into 3.5 in segment 7, showing washout on portovenous and delayed images. Adjacent mesenteric lymph nodes deposits, finding suggestive of neoplastic lesion. What could be the next step in the workup of this patient?
So, by says Pfizer Ali, Khalid says alpha fetoprotein, and biopsy. And yes, has asked HIV status.
Negative. HIV status was negative.
she is a transplant patient, remember? So she is highly immunocompromised still. Okay, next.
Okay.
So we did a biopsy.
We did a biopsy and that was showing that portal tract shows sheets of plasma cells. Immunohistocytochemistry markers were applied and findings suggestive of IgG4 related liver disease. There was no evidence of tuberculosis, fungal infection, or malignancy. So, a brief about IgG4 disease, that it is an immune-mediated fibroinflammatory condition that is capable of infecting many organs like salivary glands, autoimmune pancreatitis, retroperitoneal fibrosis. But as this lesion was and not explained by this IgG4, these radiological findings. So we, our team, hepatologist and transplant physician, to do rebiopsy of the lesion. Because of suspicion of hepatoma, as patient was also having HBV infection. Continue. Should I continue? Hello.
Yes. So Rabia is sad, or worried and sad.
Yes, sir, I'm worried and sad because it's not fitting in any of the DBs that we gave.
So one question I have is can the alpha fetoprotein be normal in hepatoma?
No.
Can it be? No.
Yes,
Can't be.
sir, it can be, I think.
No.
Well, still with normal alpha fetoprotein, the hepatologists were of the opinion that they should go for a second biopsy.
I think one thing is important. The definitive diagnosis is histopathology, and if histopathological findings are not suggestive of some atypical or malignant cells, then obviously in that case we need to go for maybe rebiopsy or something else.
Okay.
So a biopsy was done.
This is a picture beyond our scope, but
Beyond our scope.
beyond our scope. This is the lesion, and this is collection of epithelioid cells surrounding this lesion.
A lesion surrounded by epithelioid cells like a granuloma in the liver. This is the liver biopsy. Repeat liver biopsy.
Target segment 7 liver biopsy.
And a larger view. Can anybody pick something?
Okay. So can anybody see something? Or is it like histopathology when I was in medical school that everything looks purple and you make up things when the teacher asks you?
So what stain is this?
Okay, so got a good question. So let's start with this. What stain is this? Can somebody type or say? HNE, Wajid says.
Yes. Correct.
HNE Faisali also says. Yes, so correct. Can you point us in the right direction? Not pointers. No, don't point. Achha, okay, fine, point. There. I saw Gola. So there's an oval, straight looking mass, something pointed and then disappeared. So here, okay.
What is this?
So it looks like a hair inside the slide. No. So what is this inside? Do you have a more magnified view? Yeah, is this the only one?
More images? Okay.
Yeah. Okay. So we have another image.
This is stain. PS.
Yes. This is PS. Yes. And can you?
Why do you say this is PS?
Periodic acid shift. ना blue. इसमें pink चीजें आपको दिखाई देती हैं. The difference is
it stains the carbohydrates and become.
So HNE is a little lighter, but in this you'll see a clear outline in pink if it's a periodic acid shift positive, whatever you're looking for. So yes. I'm going to be quiet now.
Can anybody pick up things?
This one. This one.
Okay. Can somebody type what this one is? What that is?
Copy paste me then.
Oh, so Kokab Javeen says hyphae.
Okay. What type of hyphae?
It's a very good answer, Kokab, since fungal is what Faiza Ali says. Because PS and kuch lamba they pointed out, so imtihan mein acha jawab hai. So the question they ask is what type of hyphae? यही पूछा ना?
Yes. Septated
Can you
IV.
give us a multiple choice?
No. They
No.
are very much
Okay, okay.
obvious.
So Sana Tahir says septate, Wajid said septate, Faiza says, how about fungal stain?
Well, this is a fungal stain. PS is a fungal stain, and we are
Yes, it
yes,
is.
right. We are seeing a lot of septate hyphae packed with septate hyphae. The whole you can see lamba lines nazar aa rahi hain. These are all fungal elements.
Yeah.
packed.
So since I am horrible in slides and it's difficult to appreciate septation, Faiza Ilyas says, can you point out some of the lambe? It still looks like spaghetti to me.
Yeah, we are spaghetti alike.
This one
Okay.
looks of acute angle, and here's the
Acute,
septate.
not yes, acute, yes.
And these one, another, this one.
Okay.
So
And
there are
Kokab says non-dermatitis. And septate nazar aa rahe?
Septate बहुत मुश्किल से नजर आ रहा है, बहुत देखना पड़ रहा है कि there are few.
Non-demataceous हम इसके ऊपर नहीं बोल सकते, क्यों नहीं बोल सकते? Demataceous की क्या कैसे पता चलता है? What is demataceous?
That's a good. पहले ये इसका जवाब कोई दे कि dermatitis, non-dermatitis का मतलब क्या होता है? Mariam says aseptate.
No, not necessary. Demataceous can be septate.
What does dermatitis mean?
Fellows, what does demataceous mean? Our fellows.
Demataceous are always separate, just to clarify. They're never aseptic. So, but,
No, but
what
what is
does it
demataceous?
mean? What is demataceous?
Fellows, what do you mean by demataceous, Dr. Kashif?
Dimorphic.
No, they are not dimorphic. They can. Well, demataceous are not
They are
dimorphic.
brown pigmented fungi, demataceous
Yes.
fungi.
Black.
Melanized, बिल्कुल. Melanized fungi, बिल्कुल. जो clear cut, brown, black pigment.
Those are non-dermatitis, you mean?
No, जो demataceous होते हैं, they are described as melanized, or those containing melanin. So yes,
So just like the skin has melanin, we can remember that the dermataceous has melanin.
No,
Is that how
it doesn't have an R, but yes, close. Yes.
याद रखने के लिए.
हाँ, बिल्कुल याद रखने के लिए, just like skin, derm, but without the R. See, without the R.
Okay, good. So, and then to answer, who can answer your second question that you'd ask? Why?
कैसे पता चलता है? How do we know? How do we identify them? How do we identify demataceous on microscopy? So remember, there are two types of microscopies. So you'll be telling me about two different things. एक होती है microbiology की microscopy, जो कि KOH वाली होती है, and this is histopathology की microscopy. Okay, so people can give me answers on both. KOH पे कैसा लगेगा और histopath में क्या आएगा?
KOH में कैसा आएगा?
तुक्का लगा लें. You have a 50% chance of getting it right.
When you get septate hyphae, you should do that, and that is also important. Yeah.
Histopathology वाले में black ही नजर आता है.
Histopathology में black नजर आता है. I think they all appear black in everywhere.
No, they don't. No, they don't appear black on H&E or PAS में नहीं पता चलता. H&E पे पता चलता है. Light gold color आता है. But वो भी बहुत sharp लोगों के pick करने से. But primarily the melanin है ना. What is melanin?
It's a pigment.
It is a pigment. कोई चीज है ना, कोई chemical है, right? To identify a chemical या कोई protein या कोई ऐसी चीज आपके पास होती है, तो हम histopathology को पे कैसे confirm करते हैं कि वो है या नहीं?
Stain डाल के?
Yes. So you put something, you use a stain which can identify whether there is melanin production or not.
Okay.
Right.
With stain.
Right. So Fontana Mason stain on that.
Okay. So Fontana Mason stain for dermatitis
Melanin.
mold,
For
which
melanin
has
production.
melanin.
No,
And
not
Cockup
just
says
that.
QH will be damage.
मैं
And
सिर्फ इसे कह रही हूँ
Cockup
melanin
says
production के लिए. And remember, there are some fungi which don't have to be brown to produce melanin, the ability to produce melanin, and or bind to melanin. इसलिए कह रही हूँ. So Fontana Mason stain जो है वो crypto में भी use किया जाता है, helpful होता है. Anyway, but I'm going to get quiet. इसमें rule out के लिए बहुत जरूरी है.
Okay, so bottom line, you can't PS may you can't tell, HNE may it may be slightly gold. Magar use the which stain was it?
Fontana Mason.
Fontana Mason for melanin. Perfect. Okay.
Okay.
So
Fine.
again. Very good. Thank you.
The histopathology findings were acute angle branching thin septated hyphae seen on PAS stain along with chronic active hepatitis. So based on this histopathology finding, we opted for fungal biomarkers. The serum galactomannan was 10.92 and beta-glucan was 523.43. The final diagnosis made was invasive hepatic aspergillosis with underlying IgG4 related disease and active hepatitis B virus disease. Management antifungal voriconazole was started along with antiviral entecavir. What were the management issues we faced while managing this patient? So this is his baseline liver function test, which were normal as earlier before, with except the slight rise in gamma GDT. Fungal biomarker were 10.92 galactomannan beta-glucan was more than 500, and she was on voriconazole. 1 month post-treatment with voriconazole, although her fungal markers dropped and the lesion regressed, but gamma glutamyl transferase rise up to 830. And after 3 months post-treatment, her gamma GDT was 1000 and galactomannan was 4.32. And due to this drastic increase in gamma glutamyl transferase, we switched from voriconazole to amphotericin. At 4 months of the treatment of with antifungal, as we switched from voriconazole to amphotericin, her gamma glutamyl transferase was decreased to 557. But as we repeated the imaging, the size of the lesion initially triphasic we did before treatment was 3.5 into 3.5, and after 1 month when we followed, the lesion regressed. But during this time she was followed with ultrasound, and that image was a same size as the second image, which was basically regressed. And meanwhile her creatinine was also raised, and she had an element of graft rejection, for which she received pulse steroid. And then at 6 months, her GGT 343, and again she was started on voriconazole, and creatinine was 1.78. There were two things going on. One thing was voriconazole induced deranged LFTs, and also although there was an element of graft rejection here, but as amphotericin is a nephrotoxic drug, so maybe this creatine was also attributed to amphotericin. Because when she was switched back, although she received first steroid, but stopping amphotericin, her creatinine was again 1.78. This was the comparison of radiological findings. This was the first CT scan before treatment, and the arrow is showing this lesion. And then at 6 months post voriconazole and amphotericin, and again voriconazole, this is the arrow showing the lesion which has regressed. Fine up to here. So at 1 year, we were following this patient. At 1 year, her fungal markers galactomine was 0.68, and the lesion was same size as the previous image, the image which was regressed, that image, not the initial one. And it was decided to stop the antifungal treatment at 1 year, after 1 year of completion. And this increase in creatinine is something related to graft dysfunction, for which she is under the care of a nephrologist and transplant physician. 1 month after follow-up after stopping treatment, her LFTs were normalized, except still gamma glutamate transferase was 183, and galactomine was 0.44. With repeat imaging on ultrasound as persistent of residual lesion. Repeat liver biopsy was done to rule out ectofungal infection, and it was showing no fungal element. So a bit up to the best of our knowledge upon research of the literature regarding hepatic aspergillosis infection, it is a rare and life-threatening condition. It may present as a disseminated infection or solitary hepatic lesion. From in the coming slide, we are showing until 1960 to 2022, only 22 cases yet have been reported, and most of them, out of 2214, were related with hemato-oncological malignancies. And upon following these patients, 22 or 9 of those patients had died, as shown in the coming slide. This is a slide which showed that the gender ratio was equal 11 ratio, 11 male, 11 females. As you can see that majority of the patients were related to aplastic anemia, AML, monoblastic leukemia, ALL, non-Hodgkin, AML. Renal transplant were only 2 patients. One was kidney liver transplant together, and one was only this patient at 4th number, male patient who had renal transplant, had aspergillus in the liver. Disseminated aspergillosis also, some were having only isolated lesion in the liver, and other were showing there was in the lung or abdominal wall, involving the abdominal wall. One was disseminated, and only liver were few, and majority were hemato-oncological malignancies. And they received different treatments, amphotericin, voriconazole, and switching on at different times. So this was all about. Now, questions to be discussed.
So this patient surprised us because we were thinking of hepatoma or some strange type of an IgG4 disease. But when the biopsy came and they called us, we were little bit taken aback. How can a patient get liver aspergillosis without any history of central line or some kind? But when we asked her, we probed more deeply. We found that she had a history of leg trauma some few months back, and she said that she had some debridement done and had a putty there for a few months. So maybe we thought that that putty had got those spores in it, and then she got the in the blood and finally the liver. So that was our thinking. But this is really a rare case, and we followed her very closely, and we successfully treated her.
I'm sorry, I didn't. I missed a few things in the beginning. I just wanted to know, there was absolutely no lesion in the lung, in the sense that कोई possibility उसकी नहीं थी, कोई मतलब dilated airways या कोई ऐसी चीज, colonization.
No. That was
sinuses also.
Nothing.
Okay.
So, any comment?
Chat में तो नहीं आ रहा है, because people they don't. Okay,
so Faiza is saying it's a very good one. Dr. Faisal, please read that.
Yeah. Okay. So let me ask the questions one by one. Niche, upar se niche. So, so one question which Faiza Ilyas has, which I also was wondering, is biopsy necessary to check clearance, or we can do non-invasive investigation like CT scan to look for lesion?
When in this case, the hepatologists were very hyper, and they keep on doing biopsies on and off. So they were thinking of hepatoma again and again, and they did biopsy by themselves. So yes, not necessary. Definitely, it's a very invasive procedure. We can only go, but it's reassuring for us that the lesion is clear. Otherwise, we may end up giving her voriconazole for a very long time. But we stop it at one year. Yeah,
I agree. I think for me, a static lesion is probably equivalent to cure. I wonder if, and I don't know the answer to this, but I wonder if something like a PET scan would have been helpful in trying to see if it was an active lesion or not. Anyway, so next question by Kokab is, what is the standard duration of treatment in such cases?
Duration, don't know, Dr. Faisal. Well, here tomorrow, I don't know exactly.
So duration, I guess I also agree. It depends on your mood in the clinic. Okay,
no, but I think it's a genuine question in the sense that how do you follow and when do you stop?
So I'd love to hear what Dr. Ifat and Dr. Naseem and other ID physicians, I can't see the rest on the list, say, but generally for me, for these sort of lesions, including mucor, it's usually when there's stability in the imaging is when I say, okay, it's done. So because complete response to nahi hota, you still see a little bit of scarring. So that's how I judge. I don't predefine how many days I would give it for. But I'd like to hear what.
Yes, it's a very bad drug. It causes a lot of hepatic problems, vomiting, etc. So we successfully treated her till 1 year, but she had a very up and down course with vomiting, sometimes abdominal pain. Then LFTs rose to around 1,000, the gamma GT. So we were very confused whether to stop or continue or stop or continue. At one point we shifted her to amphotericin, which caused her kidney to fail. So there are problems, yeah.
So I have a couple of comments on that, but let me just go around the questions first, because Faiza Ali asked, can construction work all around us can also be a cause for aspergillus like this?
Well, yes, maybe. Yes. I don't know. Yeah.
So I think that's what Javeri had pointed out to, and I agree. I think that's a really important point. In fact, we've seen outbreaks over here associated with construction, and not even construction which was close to the ward, but downwind from the ward, leading to sort of pulmonary aspergillosis in a bunch of children. So
yep, exactly. Downwind, even that.
Downwind, exactly. It was downwind from.
There are wonderful papers on these as well. And we should talk to our pulmonology colleagues as well, because I do know that they have they said that during the time when the red line, green line, it was being constructed, so uske literally on either side, matlab addresses sub patients ke na around that area the jo people used to come with a lot of ABPA and CPA ke problems. So just ye bhi hame, this is something that we need to remember, and, because we do have a lot of construction.
We do. So in our case also, we saw an upsurge in pulmonary aspergillosis in our oncology ward, and we'll be only in 2 bays of the oncology ward, which are close to the door. And when we sort of looked around, we found out outside on the sort of a good maybe a distance away, there was construction happening, and not just construction. The construction was in the OR, and they were dumping the stuff in the OR on the zameen over there. And we felt, and normally you're supposed to tie it into a bag and then throw it, but they were just sort of throwing the sacks down. And we felt that probably led to increase in spores, which then sort of transferred in through actually 2 set of doors into that unit. So we stopped that, and that sort of got better. Okay, so then the next question by Faiza. Faiza, can you unmute and ask? You said, or can we believe galactomannan? What did you mean by can we believe galactomannan?
Sorry, sir. ये actually ना continuation थी जो हम discussion कर रहे थे ना कि why do we need to go for biopsy? So can we do?
Okay.
Sorry, this
next
वाला comment. Sorry, extremely sorry. वो भी उसी के साथ connected था. You can ignore those.
Okay. And then Sabiha has asked a really difficult question that I'm wondering why they made a diagnosis of IgG4 disease initially, and also did you send for IgG4 and IgG levels, and if the patient had any other clinical feature like asthma or chest infections.
So from clinical point of view, she does not have any history like suggestive of some autoimmune disorder going on. But histologically, as there was plasma cells which were pointing towards immunohistochemistry was done, and in which there was chain of kappa and lambda which were equal in proportion. So because we don't have a specific IgG4 to detect in plasma cells, so it was, you can say it was suggestive of IgG4 related disease, but not confirmatory at that time.
So I'm sorry, I would like to differ here. SIUT के अंदर जहाँ तक मुझे पता है, they had this antibody against IgG4, number 1. Number 2, for the IgG4 related disease, there's classical histopathological features based on which you can only say that yes, it is IgG4 related disorders. And I know कि वहाँ पे IgG4 or total IgG levels भी मौजूद हैं. I mean, there should have been some supportive evidence to say कि ये IgG4 related disease है, क्योंकि फिर उसकी implications अलग है ना, management will differ करके, you can give higher dose steroids and to manage it. So that's why I'm asking.
Yes.
Dr. Sabia immunologist हैं तो बहुत खौफनाक सवाल पूछ रही हैं, लेकिन ये हमें नहीं पता. हम immunologist से पूछते हैं कि उन्होंने ये IgG4 क्यों दिया था और फिर उन्होंने करा क्या इसके बारे में, क्योंकि in the end they just back off कि no, IgG नहीं था ये. I don't know why.
So
Okay.
SPEP and UPEP were done that were not suggestive of some related to myeloma or something else.
Okay, so iska jawab mujhe bhi nahi pata. So the next question by Rabia is, what is the minimum duration of invasive aspergillosis in liver in transplant patients? Asma, do you want to, or SIT, do you want to answer?
Treatment, duration of treatment.
Yes, in invasive aspergillosis in transplant patients.
Okay.
For pulmonary, I think we usually give 4 to 6 weeks.
6 weeks, and again, if we have a get to many levels, we follow it. We follow the patient closely. Again, no answer, but minimum of 6 weeks, and then maximum don't know. Maybe 1 year, maybe 6 months, sometimes. CNS lesions, more than 1 year. Again,
Until they can.
Side effects बहुत हैं. It's very difficult.
And then the other question.
2 years से हम उसको पोस्टमोल दे रहे हैं, कभी दे रहे हैं, कभी नहीं दे रहे हैं. So he's holding on, the little boy.
The other question is, also she developed cholestasis on Vori initially. Later on reintroduction, she tolerated it. What could be the reason for this? This is again from Rabia.
Okay.
No. So I have a question related to this also. That did we do voriconazole levels?
No. We didn't.
So I think that would be something that we should be doing, especially in a transplant patient with drug levels may be an issue, given the other interactions and invasive disease. So and voriconazole levels are now available. Shawkhane mein bhi hota hai, yahan AQ mein bhi hota hai. And what I found that in patients jinke LFTs kharab ho rahe hote hain, the levels may actually be too high, and sometimes I've seen people with almost undetectable levels on standard dosing. And we've had to go up on the doses.
That's a very good point. Thank you.
This was the reason. But regarding one question was that should be, is there any, indication for introduction of voriconazole if the patient initially don't tolerate it? So the literature says that we can reintroduce, and the most common reason behind the toxicity is, as you said, it's because of high drug levels. So when we reintroduce voriconazole, luckily the patient has tolerated. So we don't know exact reason why the next time she has tolerated.
The other thing is I tend to, and I may be wrong, I would like to hear what other people do, is agar sirf GGT bada hota, to I just ignore it. So and I just say ki, theek hai, forget it. I find GGT the most annoying of them. Chinko bhi to बढ़ जाता है वो.
वैसे voriconazole के package insert में exact वो भी लिखी हुई क्या चीजें आप follow करें. So
लिखी हुई है, अच्छा.
हाँ. I
but
see.
Again, gamma GT is progressively rising from 75 to 1000. So it looks some drug related rather than.
But the question is it enough to stop the drug?
हाँ, ये I think उसमें guidance है कुछ. उसका adults में I think 5 times का दिया हुआ है.
For GGT or AST?
No, but I can't remember, Dr. Faisal. मैंने भी खोला नहीं है. But you know, it's freely available online, so you can look at voriconazole. I think वो है.
I will look it up. I'll be talking. The other question is by Faiza Ali: is role of POSA versus Vori to avoid liver issues?
Well, that's a good question. POSA हमारे पास है नहीं, बहुत ही मुश्किलों से एक पेशेंट के लिए हमने अरेंज किए. तो इट्स issue of availability. Cost, yes. So I think posaconazole for aspergillus ke liye, is it fine? I don't know exactly.
It should be okay. POSA other issue. Yeah. But the POSA issue is the same as Vori issue, is erratic absorption.
Okay.
और POSA का बहुत बड़ा issue उसके लिए we use it as salvage for we use it as salvage for mucormycosis. क्योंकि
इसमें हम सैल्वेज कह सकते थे अगर हम 6 महीने बाद से चेंज कर देते, बट इसे हमारे पास थी नहीं, हमारे पास अवेलेबल बहुत मुश्किलों से होती है एक पेशेंट के लिए फॉर म्यूकोर.
And हमको मिल जाती है, लोग पता नहीं कहाँ से ढूंढ के ले आते हैं. But it is expensive.
लोग लाते हैं या हमारी फार्मेसी में.
हमारी फार्मेसी तो कुछ भी नहीं करती.
अच्छा से.
एक और how about Caspo? That could be used as salvage.
Okay.
Yes.
It's a good
And
idea.
it's been used in quite a few patients with hepatic aspergillus.
But Casper की
Hmm.
IV है, हमको IV देना पड़ता है. That's a good idea. And the voriconazole level is also a good idea. We'll do it next time.
This is something that I'm finding now that I'm doing more and more levels. So I generally do levels. I think it's recommended to anybody with severe invasive aspergillosis to do levels when you switch to oral, especially agar aap IV nahi de rahe the. And then I think that's the end of the questions. And
Then one
did
last
you run into?
So one
Yes.
last question. So do we
Yes,
the speciate aspergillus like this is fumigatus, TDS? Do we do that? Did we do that? I forgot in this case.
No,
No, we
have just got histopathology specimen from liver biopsy, not for culture.
as usual.
So for the fellows, why are they calling it aspergillus if it did not grow? There are many non-dermatious molds.
Hello.
With septate hyphae ना बहुत सारे हैं.
Let's
Why
say
they
बहुत
are
सारे
called-
लंबी लिस्ट है.
why-
सबसे
why
लंबी
they
लिस्ट
are
उसने उन्हीं की है.
Yeah. जवाब दें. Why we are calling
Doctor,
this?
I can see Dr. Javeria itching to answer.
No.
No, I'm not. I'm reading my emails.
Too senior now. बोले भाई. Acute angle branches तो dementia में भी हो सकता है.
हाँ हो सकते हैं. ये PS था. PS में तो भी डॉक्टर जुबैर ने सिखाया कि वो आप बता नहीं सकते.
Yes.
क्या आवाज नहीं है.
Galactomannan was very high.
Galactomannan was very high. So what other? So BDG? No, not Pfizer says BDG. Cogup says BDG. Beta-D-glucan. So नहीं. Beta-D-glucan तो हर mold में ज़्यादा होगा. Which molds don't give a high beta-D-glucan? पहले वो कर लेते हैं. Cryptosporidium is arguably maybe a mold. Sorry, fungus.
No, it is not.
It's not.
Cryptosporidium is a parasite.
I was scared that maybe it is, and I didn't know. So I just said maybe.
Stool में आता है. It's the one that.
Okay, so Dr. Javeria is emphatically telling us that no, so not so not Pfizer, that's cheating. You can't say parasite doesn't give you high beta-D-glucan. Then also say Klebsiella doesn't give high beta-D-glucan. Which fungus does not give? Which fungi don't give high beta-D-glucan? It's like pneumonic tiger. I remember एक दफा बनाया था मैंने.
Blastomycosis, mucormycosis,
Yes.
and cryptococcus.
Yes, BMC, blasto, mucor, and crypto. But coming back to this question, Rabi also answered MBC. Coming back to this question, which other molds give you high beta-D-glucan? Galactomannan.
Other than aspergillus.
Other than aspergillus. And the good thing is, since you're not here live, I'm assuming you're very rapidly Googling.
हमारी ये कि galactomannan किसमें aspergillus के अलावा किसमें positive आ जाता है?
मुझे एक का पता है, बजबेरे को और भी पता होंगे.
क्या चीज? Sorry, I missed. What were you talking about?
Galactomannan, Aspergillus clava और किसमें positive आता है?
And we should not technically call it false positive.
Huh?
Because
No, not false. Yeah.
हाँ.
Sorry,
क्योंकि
I didn't mean
false
false.
generally हम reserve करते हैं for biological false positive, यानी कि दूसरे non-mold derived से. जैसे for example gauze है या इस किस्म की चीजें. Sorry, beta-D-glucan की बात नहीं हो रही है, ये galactomannan है. तो galactomannan जो biological false positive है ना, वो non-mold derived चीजों से जब होता है तो उसको हम false positive कहते हैं. But when it is mold derived, then we can say it can also be increased.
Okay. Okay. Some people are answering back. Sorry, I was Faiza says, wait. Faiza says penicillium. Sana
Yes.
says fusarium.
Yes.
And Marine says alternaria.
Well, it's not written, but agar we have, I don't know, alternaria में भी हाँ हो सकता है. There were some very few case reports जिसमें था.
Okay, so alternaria and TK.
Alternaria
so in
is
other
what?
words,
Is a black mold. Just sorry.
it is.
It's a black
Alternaria
mold. It's a
is a black mold. So penicillium, alternaria, fusarium, scedosporium में भी आता है, Javeria?
Yes. So the three that I always remember as the differentials for Aspergillus on biopsy as well as on O are penicillium, fusarium, scedosporium. ये तीन. They look very much
Penicillium,
like
fusarium,
and scedosporium.
Okay, FPS, Falcon Public School, BMC and Fabric.
So these three, histopathology पे भी बिल्कुल width of क्या नाम है hyphae वगैरह quite similar हो सकते हैं, and that is probably the reason why. लेकिन वो the actual biochemical also का content galactomannan का वो Aspergillus like होता है इसका, so it does catch इसके अंदर आ जाता है. So there are different kits which for galactomannan जो interestingly अब भी हमारी most popular तो Aspergillus के लिए ही है, Platiella जो most commonly use हो रही है पाकिस्तान में भी, लेकिन there are other options जिसमें you can differentiate between the galactomannan from penicillium, galactomannan from fusarium, galactomannan from other molds. So you have that too.
Okay, so you're saying there are other types of galactomannans also? That's what you're saying?
Yes, and yes, but not available in Pakistan abhi tak.
Okay, so and just to wrap up one answer, I looked up the package insert, and essentially they said you stop voriconazole if you have hepatic dysfunction, symptomatic hepatic dysfunction is what they're saying. So patient management should include discontinuation of VFEN must be considered if clinical signs and symptoms consistent with liver disease develop attributable to VFEN. So if there's symptoms, then you would do it. And the other one is they do mention the upper limits, like you said, Javeria, but that's only for total bilirubin, AST, ALT, and alk-phos, and that was based on the studies. So in the study, they marked this as clinically significant, but stop you only do if there are clinical signs, symptoms of this hepatic dysfunction. Okay, so I think we're done. Ek aur cheez the maaf mein I think we can wrap up.
I just wanted to point out, Pfizer had mentioned कि fungal PCRs भी हो सकते हैं, and I was just saying कि sometimes you get disappointed because surgeon ने उसमें भेज दी थी biopsy formalin में, so there is a you can do formalin fixed tissue में से वो extract कर सकते हैं, DNA extract कर सकते हैं, and you can do a PCR on those as well. So just letting you know, or biopsy पे वो भी होते हैं immunohistochemical stains against Aspergillus, and you can identify that too. तो वो भी options हैं, और blood में भी PCR किया जा सकता है for invasive aspergillosis.
So excellent. This was a great case. Thank you. The only last thing, yes, sorry, I just want to ask any of the fellows who can tell me, this person got voriconazole for 1 year. What are the particular side effects in long-term voriconazole use? It's peculiar enough that it may come in the imtihan. Long-term voriconazole use ke side effects.
Skin cancer.
Vision problems. So vision problems can occur, but that's usually short term in about 30% of the people initially. Long term में क्या होता है? दो cheesein. Okay, I'll just tell you Taki we can finish. It's past 5. The first is you get there's a lot of fluoride in it, so you can get hyperostosis, and which can lead to sort of abnormal bone growth, but also a lot of body ache and joint pains. And the other one is Mohiddin said skin cancer, and you're absolutely right. So it can cause skin cancer. So those are the 2 things you have to watch out for in somebody on body for like this long.
Okay.
Okay, Allah Hafiz.
Thank you.
Thank you. That is.
Thank you.
Nafis.
Nafis. Leave them.